Good afternoon, and thank you all for coming to what will be the last MTW seminar of this year. So it's my great pleasure to invite Dr. Claire Hansen from the University of Alberta, or University of Calgary in Alberta.
Flames over oil.
So Claire initially started as a marine biologist studying boats off the coast of Alaska, before studying medicine at Simon Fraser University in Vancouver, and then doing a postdoc at UCSF, looking at the effect of the environment on pulmonary fibrosis. It has gone on from strength to strength since that time, and is now an associate professor at the University of Calgary, and is going to tell us about the environmental impacts on pulmonary fibrosis. So thank you very much, Kay, for coming.
Thank you, Gisela, for inviting me, and thank you to Natasha Richmond for coordinating my day. I've had such a wonderful day meeting people, and especially people that I've worked with and met online, but have never actually met in person. So it's a real honor to be here. Thank you very much. So I'll be talking today about the impact of the environment on pulmonary fibrosis. And you'll note I used to have my Twitter logo on there, but we've all moved over to Blue Sky. So please feel free to join the academic community over there. Here's my pitch. Yeah. These are my disclosures. And my objectives today are to understand, or at the end, for you to understand the role of the inhaled environmental and occupational exposures in the development and progression of pulmonary fibrosis. We'll be reviewing much of the epidemiologic data, but also some mechanistic data that support the role of the environment. And also to appreciate the importance of social and spatial determinants of health on pulmonary fibrosis. I think that's an important component to bring into any presentation or discussion where we're talking about the environment, because they don't really get brought up anywhere else, but it's really an environmental exposure. So why do I care about this? So I grew up in Vancouver, and in the typical West Coast vernacular, I would be a total granola back in the day. And I find the environment, as I mentioned, or Gisela mentioned, I'm a marine biologist by training. And I think the environment is extremely important in all of our lives, and it contributes to our wellness and potentially our disease. But also, the number one question my patients ask is, why did I get pulmonary fibrosis? The number one question that patients' family members ask is, am I going to get pulmonary fibrosis? And I think looking at the environment is going to help explain this. So I borrowed this slide from Professor Jenkins, that basically, you start out with a nice healthy alveolus, and then a whole bunch of bad exposures happen. Bad things happen. And then you get disease. But what we don't really understand is what those bad things are. We know that there's a genetic contribution to the development of pulmonary fibrosis. There are both rare and common variants that contribute, so both in familial pulmonary fibrosis and in sporadic idiopathic pulmonary fibrosis. But this work by Olivia Levy really demonstrated that while genes are important, the genetic liability accounts for less than 20% in the general population. So genes are obviously important, but they're not answering the whole question. So we think patients or individual people have a genetic predisposition. There's some environmental exposures that may happen. There are other internal risk factors, such as metabolism, the development of autoimmune disease, and then people can develop a whole bunch of different types of pulmonary fibrosis. And I'm interested in this particular one because I think it's modifiable, and I think it's something that we can change in our lifetime. It's something that can help us explain and understand the biology of disease, but can also be intervened upon and potentially help prevent disease such as pulmonary fibrosis, but other types of lung and systemic diseases. And not everything that is faced can be changed, but nothing can be changed until it is faced. And what we really noticed in this field is there has been a paucity of work and research into the understanding of how the environment impacts pulmonary fibrosis. So we can think of the environment, the complement to the genome is the exposome. These are all the things that we're potentially exposed to from conception through to death. And there are specific external environmental things like things we think about like exercise, diet, smoking, general external environment, which we have less control over, so access to green spaces, social capital, air pollution, the internal environment, so what happens internally when these happen, or when we're exposed to various exposures, and then the development of disease. It is overwhelming to think about trying to characterize this fully as the exposome, but every little bit that we're contributing, I think, helps to paint that picture a little bit better. So certain environmental exposures are clearly associated with interstitial lung disease. We'll be reviewing these main ones. There are probably several others, and they're in their nascent forms of understanding at this point, but smoking, organic or hypersensitivity pneumonitis-related exposures, occupations, and then we'll talk a fair amount about air pollution and wildfire smoke. So cigarette smoking is clearly a risk factor for IPF. About 70 to 75% of IPF patients are ex-smokers. So it's not even that the ongoing smoking is necessarily the disease risk, but that you have smoked in the past. Smoking doubles the risk of IPF. In this UK Biobank study, maternal smoking was an additive risk, and there's dose response. So this supports the causality relationship. This recent study by Katie Lee at the University of Chicago, manuscript under never-ending revision, it showed a pooled odds ratio of 2.73 for all interstitial lung disease. This relationship between smoking and all ILDs was there, but it was strongest for IPF. So it's clearly a relationship with IPF and smoking. But other inhalational exposures are important. These are data from our Canadian Registry for Pulmonary Fibrosis. And we think that there are certain forms of ILD that are obvious exposure related, but actually almost half of every patient with an interstitial lung disease has what we think of as an ILD relevant exposure, whether this is birds or mold or farming or dusts, metals, and inorganic exposure or both. So this is across IPF, connective tissue diseases, HP, and even patients with unclassifiable disease. So these are really common. So either the exposures themselves are really common, which they may be, and we just happen to be asking about them, or there's a relationship between these exposures and the subsequent development of disease. So the most classic, beyond asbestos causing asbestosis and silica causing silicosis, we'll come up a little bit. We think of hypersensitivity pneumonitis as being a classical exposure-related disease. And these are the two guidelines that were published in 2020. This is the ATS-JRS ALAT guideline, and at the top is the high-resolution CT scan pattern. It's really important, as is the history of an exposure. And so those two make up sort of the most fundamental components of diagnosing HP. The issue with this is that in the ATS guideline, it makes it seem like an exposure is really obvious. You've got a positive and a negative, and rarely in life, unless you have a clear pigeon breeder, or actually that's pretty much the only scenario, or there you can hear cockatiels squawking in the background of your phone call. It's much more gray than that. So in the ACCP, or the CHEST guideline from the United States, that nuance was established a little bit better. Whether you have an identified exposure, some of the time indeterminate is usually where we find ourselves. We're like, wow, they have a down pillow. Is that the cause of their disease? Or if it's completely unidentified. But exposures are clearly important in hypersensitivity pneumonitis by their very definition of the disease. And antigen identification, so finding that exposure, is really important. So the lack of an identified antigen is associated with an increased risk of death in patients with HP, and that ongoing exposure has been associated with accelerated lung function decline and death in patients with HP. So it's important to find it if you can and get rid of it where possible. So this study came from our CARE PF registry and was published by Monica Mullen, who's currently doing research with Sam Janes on lung cancer screening cohorts. But she looked at immunosuppression in patients with hypersensitivity pneumonitis, and whether, if you have an antigen identified, if there's a different response to immunosuppression. And what we found in our CARE PF cohort was there's actually worse survival in patients without an identified antigen if you treat them with immune suppression. And so this brings up this whole kind of concept that we'll get into a little bit later of what is hypersensitivity pneumonitis without an antigen. Is it HP, or is it just IPF and sort of HP clothing? So HP without an identified antigen, Haley Barnes performed the scoping review of all exposures associated with HP and found that there are about 62. We think there's like 200. It's like this never-ending list that people like adding on to. It makes it hard to conceptualize when you're doing clinical or research work, but we found basically there's 62 that seem to matter. And of the studies that we found, antigen indeterminate HP, patients were more likely to have fibrosis and progressive fibrosis associated with death. Overall, in the published studies, there was only about 17% of patients that had no identified antigen. People frequently say that it's up to half. There's a few studies from US-based cohorts that report 50% of HP patients don't have an identified antigen. But I think there's a lot of selection bias. A lot of those, it's the patients that get referred to UCSF and National Jewish in Denver and sort of quaternary referral centers are the most complicated of the complicated. And so I think that's probably an overestimate. But we still know that it's important to try to find it where possible. Occupational exposures have been reported to be associated with IPF for many years, and there was early work out of the UK looking at the Rolls-Royce factory and workers there being at increased risk of IPF. But there have been several case control studies, and when these data have been pooled, this is in by Paul Blanc as a workshop report in the Blue Journal in 2019, and then Shefali Gandhi repeated this with subsequent studies added. Basically, about 25% of IPF can be attributed to occupational exposures. And interestingly, half of patients with IPF report occupational exposures to vapors, gases, dusts, or fumes. And if I think about, anecdotally, that fits with what I see in my patient cohort, they seem to be overrepresented with jobs where there's inhalational injury. There are emerging occupational risks for pulmonary fibrosis. So I had this wonderful discussion with Dr. Fury today about firefighters. So this was shown in a Chicago cohort also that it seemed to be overrepresented, and they did find that there was an overrepresentation of interstitial lung disease in firefighters. It's been looked at in dental personnel, thinking that there's something potentially in the creation of dental amalgams. And then silicosis, there's increasing incidence of silicosis. And this study published in Thorax by Joanna Fury et al. Reported on 8 cases. This was, I think, just last year, but this year, and there's been an increase in the number overall. So these are young, often vulnerable workers that are making artificial countertops and having silica exposure. And these young people are often, the cases in the US, they're often undocumented immigrant Latino men. They're young, some are developing progressive massive fibrosis and dying. So it's a huge issue and something that can be intervened upon and prevented. So other things that have come up in the last couple of years are things like Agent Orange. So Agent Orange was a pesticide, a defoliant that was used broadly during the Vietnam War. And they have looked at Vietnam veterans getting care in the VA system in the US. And about a quarter had Agent Orange exposure. And the odds ratio for IPF, it's not high, it's 1.08, but it was consistent across sensitivity analyses and with it accounting for relevant confounders. So I think there seems to be a consistent relationship. There was something about that exposure that was probably a very toxic inhalational injury. And I don't think that it's been looked at in the local people who are probably exposed to this, unfortunately, as well. And I think research like this, I think, always makes you think, what is going on today? There are a lot of terrible things going on in the world today that are having tremendously negative impact on large populations of people, and we need to be aware of those in our advocacy. So what about after ILD develops? So we know it seems to be a risk factor for the development of different forms of pulmonary fibrosis, whether it's smoking, asbestos, silica, birds, but what about after the onset of disease? I think this has really been studied best in air pollution. So these are the defined criteria: air pollutants from the Environmental Protection Agency, ozone, carbon monoxide, SO2, NO2, PM10, and PM2.5 from various sources like industry, transportation, and agriculture. And breathing these in can obviously be a problem. But this was the first study, actually, that looked at air pollution exposure and pulmonary fibrosis. And what we found was that ozone and nitrogen dioxide, whether you looked at the mean levels of exposure, the maximum, or the number of exceedances above allowable levels, were consistently associated with acute exacerbations in patients with IPF from this Korean cohort. So I think that really brought it to light that while we think of acute exacerbations as being idiopathic, there are probably precipitants, whether these are, viral infections that we never find, an inhalational injury of some sort, but again, making them potentially preventable. We further went on to look at lung function in patients with IPF and found that the average NO2 exposure and average PM2.5 exposures were associated with lower lung function in this cohort from California. Chris Winterbottom published this looking at air pollution associated with FVC decline and showed that there was an accelerated lung function decline with PM10. most of the work and the epidemiologic work had been in sort of larger particles, PM10, and hadn't really looked at the smaller particles, which we think of as, PM 2.5, which are all sorts of particles made up of various constituents that are less than 2.5 microns in aerodynamic diameter, and they can get smaller, and you can have ultrafine particles that get even further down into the airways. And Jill Gooby, now who was at the University of Pittsburgh and is now at the University of British Columbia, has been looking fairly extensively at the associations of particulate matter and clinical outcomes in patients with fibrotic lung disease, showing that PM 2.5 exposure is associated with both lung function decline and mortality risk among patients with ILD from various cohorts across both Canada and the United States. And then went on to look at ambient ultrafine particulate matter. And this is something that is increasingly being looked at as an exposure that should be regulated. This was associated with increased mortality risk in patients with fibrotic ILD as well. PM 2.5 has been looked at in mouse models of pulmonary fibrosis, again, recognizing limitations of bleomycin-induced fibrosis, but has triggered acute exacerbations. It seems to induce type 2 alveolar cell senescence, is associated with increased cell aging markers, and overall seems to stimulate epithelial to myofibroblast and fibroblast to myofibroblast transition. So there's some mouse models that support some of this epidemiologic work. Jill's taking this a step further and looking at other mechanisms and is looking at epigenetics, so particularly DNA methylation, and has found that PM 2.5 alters the DNA methylation patterns in patients with IPF. Knowing that PM 2.5 increases the risk of death in patients with IPF, it appears that this DNA methylation seems to mediate a portion of that. So then wondering that is it occurring through an epigenetic pathway, and that the abnormal DNA methylation, she's got this paper, awaiting decision, it seems to map to fibrosis-related genes, which I think is, the first study that is taking this from our clinical observation through to epigenetics to try to understand, is this working through a clear genetic pathway? So hopefully helping to define the mechanisms and explaining why the associations exist. This is one in the air pollution ILD world. This has been one of our favorite studies over the last couple of years. And this is from the UK Biobank, looking at long-term air pollution associated with risk of developing IPF. So nitrogen dioxide, nitrogen oxides, and PM 2.5 were all associated with increased risk of developing IPF. When they looked at this with a composite genetic risk score, there was an additive interaction with the pollution exposure. So those that had a medium genetic risk and then had high air pollution exposure were at the greatest risk of developing IPF, which is one of the first studies to really look at the genetic and the environment interaction and how it leads to disease in these individuals. So this has been a big problem where I live and work. Seems like maybe less so here, but potentially relevant for many people online. So this is an example. This is a picture I took on my commute on May 2nd on my bike commute last year. And then about 2 weeks later, I really shouldn't have been outside cycling, but I thought it was going to get better by the time I came home. It got worse and it was really awful. But we have had the worst wildfire season ever recorded in 2023 in Canada. It blew all across the country and into the United States. Most of the summer between May and September was the air quality health index of 10 plus, which even if you're healthy, you're recommended to shelter indoors and have no outdoor activity. This season happened to be better, but without better policy, we were quite concerned that next year could be the same thing. And we're using this term, we have a fifth season now in Canada, wildfire season. So there's a lot of, I think, concern about the long-term exposure. This has now become a long-term chronic exposure to the general population. So it's made up of particulate matter, but there's large, fine, ultrafine, and then all the constituent components. And it's thought in general that wildfire smoke is worse than just your general air pollution that we think of, because it's burning everything in its path. Wood and organics, tires, there's chemical retardants, everything's there, and the entire population is being exposed. So I would just say, we should be advocating to prevent fires because I think they're actually preventable if you have appropriate policy, and then to consider our ILD patients in the high-risk category. So to summarize most of that, we have created this framework to think of who are the at-risk populations. So patients with disease, probably their first-degree biological relatives, anybody with a high-risk genotype, all those occupationally exposed. To what type of environmental exposures? There's several. Many of these are able to be remediated or mitigated. And then there's behavioral and policy outcomes. And the individual person, can be responsible to a certain extent for the behavioral components, but obviously not all. And the policy ones are things that we really need to have at a much higher government level so that we can prevent all these adverse ILD outcomes, ranging from worsened symptoms to death. So next, I'm going to talk about social determinants of health. So these are non-medical factors that influence health outcomes. The WHO reports that they account for 30 to 55% of health outcomes, and they can exceed the impact of biology and lifestyle. So they're obviously very important and something that I think in general in health sciences we are aware of, but it's not always front and center to our potential interventions. So these include things like income and social protection, education, employment, food insecurity, discrimination, housing, and access to affordable health care. So some of these that have been looked at in ILD include sex and gender, race and ethnicity, and often when we're talking about race, there are consequences of racism. We talk about geography, so spatial, how far you have to travel to get to a specialist appointment or get access to care, as well as your exposures and socioeconomic status. So IPF appears to be probably overdiagnosed in men and underdiagnosed in women. This has been shown in a few different studies, and survival differs by sex. Men and males tend to do worse overall than women or females. Women are consistently less represented in clinical trials and in research cohorts. There's differential medication side effects and tolerability by sex and gender. And this has been shown in a few studies, actually, lower use of antifibrotics in women versus men, even within patients with an IPF diagnosis. So Deji Adegunsoye at the University of Chicago has done a fair amount of work actually looking at outcomes by race and ethnicity in US adults. And in this study published in JAMA last year, showed that Black patients in the US are diagnosed at a younger age. They are hospitalized first at a younger age, have a lung transplant younger, and die younger. So they're losing overall several years of life. And the reasons for that remain unclear. He's also shown that Black patients are far underrepresented in clinical trials, and it's fairly well established that our understanding of the genetics of pulmonary fibrosis has been predominantly in white European populations, and we can't necessarily apply those broadly. So it's trying to make awareness and to develop cohorts of more representative patients by race and ethnicity. Geographic inequity in IPF, it really just has to do with where you live. And I think where I live, well, probably lots of places, but that are huge. I live in a huge country, and I think 95% of our population is within 100 kilometers of the US border. But there are a lot of people that live up north, and there are no physicians up north. And even if you live, 300 kilometers away, to make that drive to a clinic like mine in the middle of winter, when your oxygen's going to run out, you're just never going to get there. So this has been looked at largely in the US and Canada, but there's also a study from the UK IPF registry that just came out. So rural IPF patients, compared to their urban counterparts, are less likely to be on effective therapy. They have more advanced disease at presentation, and the VA cohort had a greater odds of IPF diagnosis. So thinking that potentially there were exposures that might be relevant in that in rural groups. We looked at travel distance to ILD clinic because I thought the hypothesis at first was all of our ILD clinics in Canada are near the border. They're in the big cities. And I thought that if you lived further away, you would be sicker at your first visit, more likely to get a lung transplant, lower FVC. And we found the complete opposite, actually. So they were younger, they were more likely to be women, and they were more likely to get a lung transplant. And I think what that reflects is that the older, sicker population is never getting sent to us. They're being managed by their local family physician or nurse practitioner way up north. They may or may not be told that they have a diagnosis of COPD. They're certainly not getting reviewed at our multidisciplinary discussion or being considered for advanced therapies or transplants. So we have a lot of work to do to improve access to care in Canada. Interestingly, in the UK IPF study that came out in respiratory medicine last year, increasing travel distance for IPF patients in England was associated with a greater risk of death. So there's certainly, I think, different health systems, different populations, different availability of ILD centers in different countries is going to impact these potential outcomes, but geography clearly matters. And this is just an example of the province that I live in. So I work down in the Calgary zone at the bottom. This is age-adjusted incidence of ILD and age-adjusted prevalence. And the incidence is highest in the central zone, and the prevalence is substantially higher in the northern zone. And there's not a single respirologist north of Edmonton. So this is based on an administrative claims-based data set, but I don't know who's seeing these patients, and we're certainly not seeing them. So I think mapping things out and using geography can really inform needs. Socioeconomic inequity in IPF has been fairly well studied. So greater social vulnerability, and these are often these combined metrics that consider a bunch of different factors, including like neighborhood level advantage. So access to education, what languages are spoken, potential pollutants, and then income. Greater social vulnerability has been associated with increased death in patients with IPF. We looked at this in a California cohort and found this relative social and environmental disadvantage. Patients had lower lung function when they were first seen in the clinic, so probably referred later, and then were less likely to be on effective therapy or antifibrotics when they had lower social and environmental advantage. Neighborhood level disadvantage has been shown, again, in the cohort in the UK to be associated with higher mortality, and then in the US, patients are less likely to undergo lung transplantation. I would imagine that would be very similar in Canada. To undergo lung transplantation requires a substantial investment of time, often relocation by the entire family, and lack of social capital ends up being a deterrent and a barrier to transplant. And this was a shocking finding for me. Tim Dempsey published this based on, these are patients that have Medicare. So my understanding of Medicare in the US is that this is generally to cover most expenses when you're over the age of 65. But even if you have Medicare coverage, out-of-pocket expenses for antifibrotics are $400 a month. So not a lot of people are going to be able to pay that, and it's going to be a substantial barrier to equitable care. So this raises the concept of environmental justice, and it's hard to talk about the environment without talking about environmental justice because they're so intertwined. So this was Nama Avitzer, who's now a fellow at the University of British Columbia, published this in Thorax a few years ago. And again, this is a California-based cohort, and it uses a percentile score using the California Enviro Screen. So this takes a whole bunch of different factors of pollutants, clean water, air pollution, other socioeconomic variables, and puts them all together into a percentile. So again, we found that the more disadvantaged patients had lower lung function, less likely to be on treatment. But the interesting thing that we found too is that a cohort of patients from the University of California at San Francisco is very left skewed. So if this were evenly distributed, you'd expect it to be uniform on all of these. These patients are advantaged. So I think what we need to recognize in a lot of our study cohorts that we're publishing on or extrapolating information from is that they may not be representative of the vulnerability of all people with IPF. So they had overall lower PM2.5, lower ozone, less risky population characteristics. So from languages spoken, employment, housing access, those kinds of things. So I think that just really brought to mind what something we're trying to overcome in our CARE PF registry is trying to reach out to communities that are more vulnerable and that have barriers to accessing our research program and our subspecialty care, because clearly this is not representative of the general population. So back to inhaled exposures, how do we find these? Well, not easily. We did a workshop, because I thought HP is my favorite disease. And I'm not supposed to have favorite, but it's my favorite. And I thought this would be the easiest disease to start with to say, well, how are we assessing for these exposures? So we're lucky enough to be supported to do this through a workshop report through the ATS. And probably the number one way to do an exposure assessment is if people have pictures of themselves with, deadly weapons like birds. It's not my pet, it's just at a zoo. But we looked at, well, what do? We take a history and sometimes use an exposure questionnaire. Is antigen avoidance, if somebody gets rid of something and now they feel better, is that diagnostic? specific inhalational challenge, serum-specific immunoglobulins, all these things that we talk about. Oh, well, maybe these things would be informative to find an exposure that's going to make a big difference for the patient. So we reviewed all the data basically and found that the things that probably work best are taking a history, using a questionnaire, and if you're lucky enough to work with, brilliant occupational respirologists, that to have a multidisciplinary assessment. Where I work, and I think across Canada and probably in a lot of centers, we don't have multidisciplinary assessment. I don't have access to people with occupational expertise. I'm often Googling somebody's job and trying to figure out what they do. We don't have industrial hygienists, which they talk about a lot in the US, but we don't actually have any. So our multidisciplinary assessment is sort of our MDT team plus Google. So I think we could probably do a lot better there. But these other things like inhalational challenge and serum precipitants and lymphocyte proliferation tests aren't feasible. The data aren't there that they're very useful. And so I think we just need to focus on the tools that we have at hand. So we created this website a few years ago called hplung.com. It was inspired by pneumotox, because pneumotox is such a helpful resource for drug-induced lung injury. And we thought, well, rather than having to log into UpToDate, which is what we use, or to like Google something or have a textbook open, we did a comprehensive literature search of every exposure that's ever been reported to be associated with hypersensitivity pneumonitis. And then we put it on this website. So you can click on it, it will take you to the original links. We didn't do like an assessment of robustness of causality. We're going to leave that to you to do in clinic because it's way too much work. And a lot of these papers are really, really old. But you can at least see, have bats ever been associated with HP? Well, there's somebody, a lot of this is birds and farming and mold. So that's going to make up the most of it. But there's like, cheese, so not eating cheese, but if you're making cheese and you're being exposed to all these molds, that's potentially going to be a source of exposure. Haley Barnes, who's at Monash University in Melbourne, but is now moving to UCSF, did a Delphi study to make an HP-specific questionnaire. So this is available online in CHEST. 18 items reached consensus, and then she tested how well it performed in clinics. So when you applied this questionnaire, it increased the confidence in HP diagnosis, for whatever that's worth. It reduced the proportion of patients that were antigen indeterminate, so this may be really helpful. And that the patients that were diagnosed with HP, they tended to have symptoms that improved with avoidance, and they tended to have daily frequent exposure. So I'd say this is a pretty good, robust questionnaire to use for HP, and it seems to fit well to help with diagnosis. We don't have a whole lot of other questionnaires for ILD. Peter Jackson developed and validated this ILD exposure questionnaire for sub-Saharan Africa. And I think it's probably one of the best exposure questionnaires that it has ever been made for interstitial lung disease. Outside of sub-Saharan Africa, a lot of things on there are not going to be relevant, I think, is the only issue. But if we could, reproducing the methods that he used, I think would be really informative. So that's there for that geographic region. There is one through the CHEST Foundation, but it's really long. It's very yes, no. And it's very unclear where they got the exposures from. And just as an example, we use this Canadian in our CarePF cohort, we use this exposure questionnaire. But like I'm asking about longshore persons in a landlocked area. I don't think it's going to be particularly relevant. I don't think there's just a lot of things on here like that aren't going to be particularly helpful. We don't have foundries near where I live, right? I don't think anybody's working at a pottery. I think largely some of these questionnaires we use were extrapolated from asthma. So what we've gone on to do, and I've been so lucky to collaborate with Dr. Fury over the last couple of years to get occupational expertise to help support this, but it's to develop an exposure questionnaire for ILD. We had 3 aims, so a systematic review and meta-analysis of every exposure on the planet that's ever been associated with interstitial lung disease, which has been much more challenging than you might think, and there's a reason why nobody's done it before. A scoping review of questionnaires, just to say, well, what's out there? What are people asking about? And then a Delphi survey to identify consensus among experts. And the purpose is to get a short form screening questionnaire that you could put in an EMR, for example, or in a family practitioner's clinic and say, well, if you've got this, this, and this, you're much more likely to have ILD, so we should do a diffusion capacity instead of just spirometry, maybe get a CT, and then more comprehensive iterative questionnaire for clinical care and research. So the systematic review and meta-analysis, 84 studies were identified. over 31 million subjects. So just trying to manage this data set has been a massive undertaking. We had to include sarcoid, asbestosis, silicosis, and HP because you'd get like 2 million abstracts come back, and there's just no way to feasibly do this type of systematic review. We grouped exposures into smoking, organic exposures, silica, vapors, gases, dusts, and fumes, and other occupations. And this is just my tribute to Katie Lee because she has put so much work and effort into this, and we hope that it will be informative and helpful once it's out. Essentially, what we found was that silica, outside of even silicosis as an outcome, silica is associated with increased risk of all ILD. Asbestos is on there as well. Other occupations like firefighting, smoking is a consistent risk factor. Other organic exposures are risks for non-HP ILDs, the composite of vapors, gases, dusts, and fumes, and then some individuals exposures. Air pollution, we probably need to update the search, but at the time, the data that we received did not support a risk of air pollution exposure leading to an ILD diagnosis. Haley Barnes did a scoping review of ILD exposure questionnaires because we thought, well, what's out there? Like, are there any ones that we could really use? There were 22 questionnaires that we found. Some were for all ILD. One was for sarcoids, four for HP. Most didn't ask about dose or duration. Most didn't explain why the exposures were included in there. And a lot of things like cats and dogs. And, for an asthma clinic, that's going to be relevant. For an ILD clinic, that's never relevant. So we really wanted to go through and say, okay, well, what's being asked? What can we get rid of? What should we keep on our subsequent one? So again, these are sort of ones that are on the published questionnaires, really common things like birds, mold, saunas, hot tubs, air conditioning, swamp coolers, insecticides, and pesticides, things that are probably missing. So air pollution is not on here, interestingly. Indoor air pollution, outdoor air pollution. There's, sort of a new interest in microplastics as being potentially detrimental and causes of disease. Vaping and e-cigarettes aren't on any of these yet, so I think we have an opportunity to improve on those. And then we took all this information and we put it into a Delphi, and I love Delphis because it's this idea that it's based on the principle that forecasts or decisions from a structured group of individuals are more accurate than those from unstructured groups. You don't want a haphazard group of people just making this. You have a nice targeted, thought out group of people providing expert opinion. So what we found basically at the end of this, we had things that are relevant, things that reached no consensus, and things that are that everybody agreed upon as clearly irrelevant. So the relevant ones should probably go on an exposure questionnaire because everybody agreed that these things likely increase your risk of developing interstitial lung disease. From auto mechanic, baker, firefighter jobs, metal dusts, wood dusts, wheat grain. No consensus on whether cooking or food preparation is an issue. No consensus on dental technicians or dentists. Clearly, we could throw out being a vet, being a healthcare worker, being a teacher. That's funny because when we think of teachers now, we still think they're exposed to chalk. You first think, what are they exposed to? And you're like, they're probably just exposed to viruses. But yeah, so we're taking that off. And essentially, we have a short form ILD screening questionnaire that hopefully should be available soon. That if you ask these questions, again, in an EMR or somebody presenting with breathlessness or cough, have you smoked? Have you been exposed to birds, bird droppings, or pet birds? Down, feather bedding, dusty environments, mold or water damage, asbestos or silica in your home or workplace. The longer, more comprehensive ILD exposure questionnaire will have residential address and smoking history, as well as occupational exposures that are more extensive, hobbies or jobs like wind instruments, farming, construction, auto mechanic, and then we'll have open-ended questions about occupational history. And the real benefit to working with occupational respirologists, and this has been to develop some of the questions to say, have you ever worked in a job that's caused you to be breathless? Have you ever worked in a job where you had to have regular breathing monitoring? I'm like, I would never think to ask that. And that's where this collaboration and multidisciplinary assessment is really helpful. So the next steps, A, to get it published, and then B, to implement it. So we'd like to pilot test it, compare it to other questionnaires, and then MDD-based diagnoses, maybe test the performance of the exposure questionnaire to identify biological result or biological consequences of exposure. So people might say they've been exposed to things, but if they don't have a DNA methylation pattern that we know should be associated with air pollution exposure, then maybe it's not been an accurate representation. We hope that it can be iterative. So we hope that we've provided an evidence base on which other people can base their exposure questionnaires, and they can be tailored to the local relevance. And you can add and remove things that if you don't have that particular job or you think something else is more relevant, you can add that on. So I hope that I've convinced you that this environmental component, environmental and occupational exposures are important along the ILD pathway. They clearly interact with a person's underlying genetic risks. And there's probably a group of patients, a smaller group of patients that have clear genetic risk factors for disease. There's a small group on the other tail that has clear environmental factors, but there's more likely a group in the middle that has a combination of gene by environment interactions. And we hope to be able to sort this out. So I wanted to share a little bit of some exciting things we're working on in Calgary in case you want to come visit, is building the Calgary Familial Pulmonary Fibrosis Cohort, which will be a prospective longitudinal cohort of affected patients, either familial or sporadic. We'll recruit their first degree biological at-risk relatives. And then what we hope would be an age-matched spouse or partner who is non-biologically related to act as a control. We'll then characterize the gene by environment interaction and follow them longitudinally to try to understand why certain people are getting the disease outcome. The other thing I hope to sort out before I retire is what is antigen indeterminate fibrotic hypersensitivity pneumonitis? Maybe it's BIP. So we are prospectively recruiting patients with fibrotic HP. We'll hopefully have about half that have an antigen identified, half that don't. And, there's no gold standard. So we're going to base this on as robustly as we can determine based on all available tools, because that's reasonable. We will clinically characterize them with CTs and quantitative CTs, get blood samples, lung and airway biopsies, and BAL, and be able to do epigenetics, proteomics, and spatial transcriptomics with collaborations here in the UK, and hopefully be able to see if HP with an antigen is the same or different as HP without an antigen, or is this like a completely different entity? Is it more like IPF? I don't know. In summary, inhaled environmental and occupational exposures are common in patients with ILD. They are associated with risks for both diagnosis, so disease onset, and progression, poor outcomes. There's increasing data that's informing the relationships and mechanisms. Social and spatial determinants of health matter to these patients, and exposure assessment is challenging. We're working really hard to figure out what is causal. I just wanted to thank this amazing group. It happens to be an amazing group of all women that I've been collaborating with over the last many years. That have contributed to all of the research that I presented today, as well as my close collaborator, Chris Ryerson at the University of British Columbia, and my mentor, Hal Collard. And again, thank you for inviting me to Imperial College and the Margaret Turner Warwick Center. Really happy to take any questions.
So thank you, Kay. That was fabulous. Have you got any questions from the floor or from? If not, I'll start by asking about how given that we can now geolocate everything, you go onto a website, you can geolocate anyone, where, in theory. Is that possible with your cohort? Can you actually track people and where they go? Because clearly, a single point in time identification of where someone lives is great for as long as they live there, but migratory patterns, etc., etc.
Yeah.
So is that possible, and what do you plan to do?
Yeah, I think there's a lot of assumptions that people spend the majority of their time in their home or their workplace, and there's lots of other places that people go. So I think there have been development. I was talking about this with Athena earlier about personal air quality monitors. So at least to be able to, you can tack an air quality monitor on a person and have it tracked around, and to be able to measure indoor air quality within their home, because we all make these assumptions that, the early modeling in air pollution exposure assumed that there was a fixed point, and it assumed that there was sort of flat ground. What you didn't realize there was a monitor, an air pollution monitor. And the person lived closest to that air pollution monitor, but in between there was a giant mountain. So actually their air quality was more associated with the further out monitor. And that was even, with our first air pollution study that we did in Korea, published in 2014. Since then has become much more satellite based. So it's evolved so quickly over the last 10 years to be much more representative. But I think the next step is going to be, Elon's probably tracking us right now, whatever we're breathing in. But to have personal monitors, and whether that's associated with some, embedded in something you always have on you, your keys or your phone, or it's a monitor somehow, I think we'll be able to do that. And I think the only barrier will be, are we measuring the right things?
First is, if you were an IPS patient and you lived in a very polluted city, would you consider moving? And I could just turn it around and say, if you were the doctor of that patient and they came to you and asked you, as we have had, probably all of us here, and say, should I move for my health? Will this have an impact? And of course, we can't say yes, it will, but if we wanted to stack the odds in our favor or in their favor, are we at the point of almost recommending that as part of our therapeutic regimen? Or if you were a family member who had a family member with IPF, they asked you, should I move out of my highly polluted city? Is there any benefit to that? So that's question one. Question two is about the fires in Canada, and whether there's any plans for longitudinal tracking of people who are exposed, and over time, whether there's some increased incidents or rates of progression that vary, based on exposure.
Yeah, and I think that first question, it's so complicated. And I think it's interesting. When I did my fellowship at UCSF, I remember one of their interventions for HP at that time was to tell people to go live somewhere else for 6 months. I was like, who can afford to go live somewhere else for 6 months? And then we've got a population of people in Alberta called Hutterites, and they live on colonies, and they're of German descent. And they frequently get HP and asthma. And we would suggest that maybe they could relocate, and they would relocate from one farming community to another farming community because that's where they had family. So it's really actually implementing that in clinical practice is hard, and it's got to be as difficult as telling somebody to quit their job. And I think it's one of those scenarios, purely for your health, say, well, yes, that seems like a great idea, but how much do you love living in this particular polluted city? And does that outweigh the potential benefits? I'd say if they feel better and they really want to do it, I would wholeheartedly support that. I don't know that we have the data that it's going to make, how much of a difference it's going to make at what financial, social cost. So I don't know that as an implementation measure, it's going to be that simple. So the family members of my patients, when they're like, oh, am I going to get this one day? And I'm like, I don't know. Please enroll in my cohort study. But I say, I'll tell you what not to do. Don't work in a dusty environment if you can avoid it. Don't smoke. Don't get a bird, and try to breathe in only clean air. And monitor. Exercise regularly so that when you suddenly are taking twice as long to do that 5K run, you get checked out and don't wait and attribute it to something else. So there are a few preventative measures. Oh yeah, don't get down bedding. That's the other thing. But yeah, if it really comes at a cost, if that person turned to me and said, well, we've had, pet cockatoo, whatever for 10 years, do I have to kill the bird? I'd be like, I'm not ready to make that decision. From a wildfire smoke perspective, there's been a huge increase in awareness and research in Canada. And actually, Paul Koobs, who's this amazing scientist at the University of Calgary, just got a huge grant to look at wildfire smoke health effects on respiratory systems in the general population across Alberta. So they're going to be doing all sorts of sampling, air quality sampling, sputum analysis, bronchoscopy, all these things to try to understand how it's impacting lung tissue. So I think there is an increasing awareness of it. But what there hasn't been up to this point, and hopefully this will increase because it's sort of province by province, and there's 10 provinces and 3 territories in Canada, is there has to be political will to try to prevent the fires. So I think that's the big issue. I go on the news every summer and they're like, oh, well, how can we protect our lung health? And for the first couple of years, I was like, close all your windows, make sure you've got your inhalers, don't exercise. And after about 5 years of that, I was like, vote, call your member, or your legislative assembly member, and advocate for a stronger wildfire protection all year long. Have them at the ready, involve land protection, because prevention I think is going to be key, because it's just been so toxic for so many years.
Thank you very much. Two things, well, at least two things that really surprised me. You didn't say very much about radiation exposure. In Canada and the UK, we've got quite a sharp grading about natural radon exposure. I just wonder if there are any data. We clearly know at a certain dose it's very fibrogenic. And the second thing, which is a comment, my father was a dental technician, and he was exposed, as they all are, to huge amounts of organic solvents, but also silica. So I can't believe that that is a group of patients that may be an N number problem. I can't believe that they shouldn't be in your high occupational risk group. If you could defend that,
Yeah.
that's quite interested.
Yeah, and I think that probably came out of not ignorance in a bad way, but I think people's lack of awareness about it from the Delphi study. And do you think it'd be interesting to find out if the dental practice has changed over time? But even historically, I mean, you would still be seeing people right now who would have been exposed throughout their career and are now into their 70s. Yeah, and did you say radiation or radon or specific?
Oh,
Okay, so I'm not as familiar with background radiation. I do know. It was interesting. I was talking with Athena earlier just about like an upcoming study of indoor air pollution and what are the things you should measure. And I meant to say radon because I'm not aware of any data with
some of the
fibrotic lung disease. Yeah, so that's something we should probably be adding into as an exposure. Yeah. And radon, we have quite high radon levels in our homes. And it's funny because even throughout pulmonary training, I don't remember hearing about it as a lung cancer risk factor. And I didn't hear about it until I went to Berkeley and did a master's of public health. And then it became this big, widely known thing. It's now much more in the news to get radon measured in your home. If it's high, to have it, vented and remediated. But it's something I think has been quite new on the horizon as a risk factor for lung cancer. Mm. The world's a dangerous place. And all of a sudden, nothing's safe.
Thanks, Perry. Fantastic talk. Great amount of work.
Thank you.
So I also have two questions. One is the study that you showed showing that silica is the greatest exposure associated with fibrotic lung disease, but you had excluded HP, SNARC, periodontitis. So does that actually relate to idiopathic interstitial pneumonias or unclassifiable?
Yeah, and
well, what was left after you excluded that?
yeah, idiopathic interstitial pneumonia is unclassifiable, IPF and connective tissue disease. So there are epidemiologic data that silica is a risk factor for the development of things like scleroderma, rheumatoid, and that the sort of small and fairly flawed studies, but with a signal suggesting that they're also within that group that have disease, increased risk for interstitial lung disease. And I think it's probably also, I think some of these studies, when you pool a lot of these data, the limitations are of the parent studies. And I think one of the things that we've come to realize in looking at all these data is there's a lot of bias in what we know. There's a lot of silica studies because everybody asks about silica because we know silica causes silicosis. We don't always know all of the origins of it, but it's frequently the data are collected and it's reported, as opposed to, we've also seen that there's a lot of male predominant occupations in there. So there are, been a few people in there with like hairdresser jobs or like working in salons, but the number of studies that have been published looking at those are much smaller than things like sort of historically men predominant labor jobs. So I think the silica part of it, it's definitely there's got a huge confidence interval, but it seemed to be consistently reported. And whether those people were misclassified, or it's just because they asked about silica in the studies because it's so well established, I'm not sure.
And the other question, sorry, was, well, I mean, we know that in Black people, Black patients, IPF is quite rare, at least in our clinics. I think about Tuesday and Friday morning clinic where we see, follow-up IOD. Almost no Black patient with IPF. Go to the Sarkri clinic, loads of Black patients. And I just have a feeling that the genetics, the occupational exposure, all of that in Black patients? Is there, I mean, we know HP in Asian, for example, there's that group of women, elderly women, where Asian tends to get what we call now HP, might be BIP, but I've seen very little about IPF in Black communities,
Yeah.
whether that be in America, in Africa, and I just was curious to hear what you think of that.
Yeah, and I live in a very, well, relatively, not very, it's a somewhat homogenous city. It is not particularly diverse. Our CarePF registry is not very racially or ethnically diverse. We've really struggled to reach out and make that more representative. It's interesting. I was having this conversation with a few people at ICLAF. And just wondering, we don't have a lot of epidemiologic studies from sub-Saharan Africa or Black predominant countries. And I always think, so if you're going to an ILD clinic in Cameroon or Nigeria, are Black patients there going to have IPF? Because we look at it through our lens of our sort of white predominant countries often, and they represent a minority of the population, but also a minority within the clinic. So I don't know if we know what the true epidemiology of that is, if there are... Yeah. And then with all of these things, we tend to feed in and have sort of our own confirmation biases. It's similar with the men woman with IPF, that when Deborah Assayag looked at that study that Simon Walsh had done, where we all had to score 60 cases, and there's all these different parameters in 2016, that the exact same clinical scenario, if it was a woman, was far less likely to be diagnosed with IPF. Than just that one variable changing. And so I think it fits in, whenever you put up, this is the classic patient with this, is the classic patient with that, it might be 60 to 70% of the patients, but it's not going to be all. And then I don't know how much of that feeds back. So I think defining the true epidemiology, I think, is always challenging. I'm not sure if that's a true, how much of the underrepresentation it is. And I know we've talked about this with there's, no MUC5B or just very low MUC5B as the main risk factor.
Taking into account what you're saying about underrepresentation, likelihood of making a diagnosis according to race or gender, I think there still is something there, but there aren't population studies that I know of
There's lots of been trying for a long time.
Okay.
But for the reason, because of the known reduction of mortality, but he has his own interest, but he thinks it's a combination of underrepresentation and MUC5B.
Yeah.
Which is often low in the Chinese, isn't it?
Yeah, it's presently low in Japanese population, lower, but
much lower.
I think it's much lower than white.
I thought it was so much less than 10% compared to our 30%.
But I mean, one of the big problems with population genetic studies is that they're all based on, white European population expansion. So we need to do the genetics in a bigger population, broader, more diverse populations.
For sure. But just to understand, also your data that you're doing a younger Black men or women, those much younger, died earlier, do they have the same disease? What do they have?
I think that highlights the point that we need to be collecting these variables also, because we're on this task force right now on sex and gender and race and ethnicity, trying to improve equitable representation across research in interstitial lung disease, and finding that in a lot of the studies it's not reported, so actually I have no idea what was in the study, and that there's a lot of different ways to adopt racial and ethnic data. And I think we often adopt the terminology. So it's interesting, we don't use words like Black and non-Hispanic whites in Canada. So I don't it's not, but I think that would be adopted to characterize those variables, but I think it has to be tailored to your populations. So I think we need to think about how we're collecting those variables and make sure that they're being collected, because again, you can't address an issue if you haven't collected the data on it.
Outcomes did provide that. Do you think it's important, and we'll get to a place in society where diagnostically and treatment-wise, we can disaggregate by sex, and people will go down different paths depending on their sex?
Yeah, and I don't know if this is kind of hopefully aligned with what you're asking, but I feel like in many levels, we're starting to realize that this is not a binary relevant characteristic. I mean, in some ways they are, and in some ways they aren't. And I think we're struggling even within the field. There are probably many fields. I'll review or read a lot of papers that will say male gender. You're like, oh, that's not even right. So that's a sex, and then not leaving it open for non-binary or intersex. So all these different ways that people exist. And I think we're hopefully starting to recognize there's a lot more complexity on this planet than simple binary variables. And I'm hoping in our lifetimes that this will all just kind of smooth out into less dichotomized.
Recently, the George Institute have been working on sex and gender policy, and they've been working with publications as well as funding bodies and getting people to disaggregate by sex and gender in supplements so that we can do big meta-analyses for transgender individuals. Even if counts alone in an individual study, it'd be great to pull them later on. So I really hope it's just progress.
That's brilliant. Thank you.
Yeah. Thank you, Kerry. And thanks for sort of going through all the complexities of the exposome and all. I mean, the problem is there's so much confounding between everything within the exposome and all the health disparities. And something that I noticed was missing, and I wondered whether it's something you consciously decided not to touch at all, is sort of light pollution. And so we had John Blake come and give a talk to us about circadian disruption and shift working and things like that as an occupational exposure. And I noticed sort of that there's nothing there about shift working or light pollution or circadian disruption in your exposomes.
Oh yeah, this is so huge. Once you really start to think about all these things that are affecting things like 5G, I'm just kidding, but maybe not. It's like, where do you contain it? Like, where do viruses fit in? I mean, that's a huge, like, technically that's an environmental exposure, I suppose. So we try to keep it. I'm just feel like the way we're trying to characterize it a little bit for research or, for a questionnaire or like in clinic, thinking about inhaled things, like we're specifically talking inhaled. But all of those things are going to be impacted by things like your circadian rhythm and sleep quality and mood disorders and metabolism and your diet. I mean, we don't touch on diet, nutrition anywhere. I mean, very minimally. Like, I'm aware of one study I can think of that just looked at how to manage side effects with a Mediterranean diet from an antifibrotic, but not looking at like overall nutrition. We're looking at frailty, but like not as an potential intervention. So I think there's a lot we're missing. And I think that all of these larger sort of holistic parameters of an individual's existence and being, if we had a little bit more understanding of those and understood effective interventions to optimize those, I think it'd probably outperform a lot of the drugs we have available. So even things like pulmonary rehab and, infection prevention and oxygen, if you qualify for it or need it, that all those things are probably, if we weighed them equally, would outweigh the benefit of all the other things. But the research, it's hard to get the impetus to focus the research on those things because there's just not the money to back it up, I think. But yeah, that'd be really interesting to look at circadian rhythms and light pollution.
Stop going outside during COVID, there was a lot less sort of exacerbation. Now, again, there's confounding there in terms of accessing the healthcare service, but people don't be quite happy to not be exposed to lots of.
Yeah, they were really bummed out for other reasons.
Yeah.
It's all a trade-off.
Thank you. Very cool. I was just wondering if there isn't possibly a bit of a link between the genetics and the environmental factors through telomeres.
Oh yeah.
We know that smoking causes short telomeres. And I was wondering whether there've been any studies. I think they have, I'm just not aware of them, of the other exposome entities and their effect on telomere.
Oh yeah, and I think I've been convinced fairly substantially that a lot of this is mediated through telomere length, and smoking, air pollution exposure, stress, of course the genetics that would be associated with shortened telomeres. That's probably a big mediating factor that's leading to many of these fibrotic diseases. And I think it's funny. I was just talking about this with Punchali today. We were talking about in Thailand having access to clinical genetic testing and whether it would be worthwhile. And my 2 cents, take it or leave it. Don't necessarily focus on setting up a clinical genetic testing. If you're going to put an effort in, measure telomere length. I think that's going to give a lot more information about risk of progression and potentially treatments that are going to be beneficial or harmful. I think there's certainly a relationship in it. I think it hinges a lot on telomeres. Thank you.
Okay, well, that's great. That's been an absolutely wonderful presentation and great discussion, and we've gone over a lot of time. So
I just wanted to thank everybody online. I saw a whole bunch of really familiar names. I just wanted to say hi and thank you for joining.
thank you